Welcome back to the What's in Your Head podcast. I'm Pete Schultz, doctor of physical therapy. Today we're talking about two conditions that could be frustrating and sometimes misunderstood: cervicogenic headache and cervicogenic dizziness. These are symptoms where the neck may be playing a meaningful role in headache, dizziness, imbalance, or when you're just feeling like something is off. I see these presentations often in my physical therapy office, especially in people dealing with neck pain, concussion recovery, stress-related tension, migraine, and persistent dizziness. Today, I'll break down what these terms mean, what the research says, how these conditions are evaluated, and the treatment tools I commonly use to help people improve. As always, this podcast is for educational purposes only and not a substitute for individualized medical care. What is a cervicogenic headache? So a cervicogenic headache is a secondary headache, likely coming from the structures in your neck. It's often associated with upper cervical spine, the joints, the muscles, and nerves that are all around your base of your skull and the upper segments of your neck. It frequently starts at the base of the skull and neck, and it could refer to the temporal area of the head. It could refer to the forehead, behind the eye, one side of the head. We often see a ram's horn distribution. It starts from the base of the neck in the occiput, and it comes up one side of the head, similar to a ram's horn. It's often aggravated by neck movement, prolonged sitting, poor posture, and sustained looking down, like watching TV from a couch or staring at your phone for long periods of time. Cervicogenic headaches are recognized in the International Classification of Headache Disorders as a secondary headache, which means that the headache itself is coming from structures in the neck. It often overlaps with tension headache and migraine. What is cervicogenic dizziness? Cervicogenic dizziness is dizziness, disequilibrium, fogginess, or motion sensitivity that's often associated with neck dysfunction. It's not spinning, so you don't feel vertigo or the room spinning. There's usually a sudden onset. It could even happen for no reason. It's worse with neck pain. It's usually considered a diagnosis of exclusion, so basically we rule out all other issues that could be coming from the vestibular system. And then if there is neck-related issues as well, it's usually considered a diagnosis then. And there's really no gold standard test for cervicogenic dizziness. So the proposed mechanism is now the neck provides constant sensory input to the brain regarding head position. So the neck is constantly telling your brain where is constantly sending signals to your brain where your head is in space. So the neck has these proprioceptors or sensors in them that are always telling your brain where your head is in space. The brain is also getting input from the vestibular system and the visual system. So basically you have the cervical proprioceptors in your neck, you have your vestibular system, and you have your visual system, and they're all sending signals to the brain to tell your brain where the head is in space. Now, when these signals don't match or they're not sending a similar message, it causes disequilibrium or it disrupts equilibrium. And then you start to feel dizzy, imbalanced, nausea, visual discomfort, motion sensitivity. So you need these three systems to be on the same page. And when they're not, it could be one of the three systems. So it could be the visual system, it could be the vestibular system, it could be the neck. So when it is the neck, it usually is a cause for cervicogenic dizziness. Now, the clinical literature supports the diagnosis of cervicogenic dizziness, and there are also some physiologic models that are supported in the literature. But careful screening is essential to rule out other cause. Also, anecdotally, what I usually see is sometimes people have other vestibular issues. Maybe they have a history of vertigo, or maybe they had concussion. And now when people are dizzy, they stop moving their neck. And when you stop moving your neck, your neck gets stiff and you start to get cervical dysfunction, and maybe some of the joints and the muscles in the neck get stiff and tight and don't work as well. Then you move your head less. And because you're moving your head less, you're not getting that vestibular input into your brain and into your vestibular system. So the vestibular system gets weakened and it slows down. Then you get more dizzy and things get dizzy. So basically, the vestibular dysfunction may have set it off, but now the dizziness is coming from your neck or your cervicogenic. So some causes or risk factors that we usually see are whiplash, concussion, people with chronic neck pain, a history of migraine, desk posture or tech neck or repetitive strain, some stress-related guarding, anxiety, hypervigilance, previous vestibular event, as I just discussed, or having a history of vestibular issues. How do we diagnose cervicogenic headache and cervicogenic dizziness? So these are clinical diagnoses based on pattern recognition and ruling out other causes. Some of the things that you have to rule out will be like BPPV, which is positional vertigo. We could rule out vestibular migraine, inner ear disorders, neurologic causes, vascular causes, medication effects, triple PD, which I've discussed in past episodes, or a primary headache disorder like cluster headache or something like that. So these are things that need to be ruled out. And then basically, when we understand that these diagnoses are all ruled out, and there's dysfunction found in the neck, we could increase the likelihood that these symptoms, whether they're headaches or dizziness, are caused by the cervical spine or caused by the neck. Also, what we're looking for are symptoms triggered by neck movement. Sometimes what I'll do in the clinic is when I do my regular range of motion testing for the neck, I'll have someone turn their head all the way to the right or turn their head all the way to the left, look all the way up, look all the way down. Now, because that affects the vestibular system also, I might have their head be still and have them move their body all the way to the right and all the way to the left so I could test range of motion while their head is still. And if that reproduces the symptoms, then I could say there's a higher likelihood that those symptoms are coming from the neck. So there are ways to tease out whether the dizziness and headache is coming from the neck or from other systems. Also, what we often find in these cases are the headaches begin at the base of the skull or the occiput. We're seeing that there's reduced cervical range of motion. So there's limited in the movement of your head turning or looking up and down. People who have cervicogenic dizziness or cervicogenic headaches will complain of neck stiffness or pain. They complain of dizziness with sustained postures, and we'll see improvement when neck function improves. So that's another way we could tell, like if their neck starts moving better and their neck gets stronger and they feel less dizzy, there's a higher likelihood that that was the cause. Now I'd like to discuss how I evaluate the cervical spine, vestibular system, visual system, how I evaluate these systems in the physical therapy clinic to determine what the treatment should be, to determine if it's a cervicogenic headache or cervicogenic dizziness, and what the treatment might look like. So first, I'm going to look at the cervical spine. When I look at the cervical spine, I'm going to really look at the posture. I'm going to have someone stand there, look at the position of their head on their body. I'm going to look at their range of motion. And like I said before, I'll often, if someone's complaining of dizziness, I'll have them turn their body while their head is still while I'm doing my range of motion testing. I'm going to palpate the joints and the muscles for mobility and looking for provocation of symptoms. So if I feel around or squeeze some of these tight muscles and it reproduces the headache or reproduces the dizziness, then that's likely the cause of those symptoms. I'm going to look for muscle tone and guarding. I'm going to look at the strength of some of the muscles of the spine, like the deep cervical flexors. When I do a deep cervical flexor endurance test, I want them to be able to hold up their head against gravity in a chin tuck for longer than 20 seconds. I'm going to look at their thoracic mobility, so how the rib cage moves and how your upper back moves. And I'm also feeling around for active trigger points. Then I'll look at the vestibular system and their balance. So with the vestibular assessment, I'm going to look at their vestibular ocular reflex. Can they keep an image steady while their head is turning? Can they read an eye chart while their head is moving? How is their balance with their eyes closed and balance with their head turns? Could they walk and turn their head side to side? I'm going to do BPPV testing to make sure that they don't have vertigo. I'm going to check their visual motion sensitivity. So have them reproduce things like spinning around and see if that reproduces to get a good idea of how the vestibular system is functioning. Then I'm going to look at the cervical proprioception. So cervical proprioception, as I discussed earlier, is how your neck communicates with your brain to tell your brain where your head is in space. So we're going to do things like I'll have someone close their eyes and turn their head to the side and see if they're turned to the right or left, see how accurate they are. Maybe I'll put a laser pointer on their head and have them see if they could locate the target with their eyes closed. I'll see how smooth and controlled their motion is, if they're able to move in a nice, smooth, controlled manner. So I'm looking at the cervical sensation and the cervical proprioception. Then we're going to look at the nervous system and stress. So really, when I look at the nervous system and stress, I'm talking about the autonomic nervous system and sympathetic or parasympathetic activity. And it's really going to ask them, how's everything going? How frustrated are you? I'm going to look at their breathing patterns, see if they're more in upper chest or breathing from their diaphragm. Ask people how their sleep is, how scary their symptoms are. When you get these symptoms, does it really scare you? Do you really feel like something bad is going to happen or going on, or you feel like these are never going to go away? Are you constantly bracing when you feel that dizziness or headache? And how's your ability to handle stress, or how is life going? Maybe you're in a stressful period of time in your life. Maybe you hate your job. So we have to address to make sure that you have stress management tools and you're speaking to the right people, or you're able to manage them with breathing exercises or biofeedback. Okay, now it seems like you have cervicogenic headache or cervicogenic dizziness. So what do? So the first thing is to know that these things are treatable, right? If it's coming from the neck, it could be treated by physical therapists, chiropractor, acupuncturists, anyone who does manual therapy. So what we'll do in these cases where we've identified there's a cervicogenic cause of the symptoms, we could do manual therapy. Manual therapy could be massage. It could be active release, any type of instrument-assisted soft tissue mobilization like Graston or other techniques. Could be manipulation, could be acupuncture. So any type of these manual therapies are meant to improve cervical range of motion, reduce protective muscle tone. So when your muscles get really tight, to protect that area, decrease pain sensitivity, and improve your confidence with movement to make you move more free and move more confident. So we could do soft tissue work. I do traction of the occiput or traction of the cervical spine. We work on the thoracic spine and some mobility of the thoracic spine. Next, we do corrective exercises. So corrective exercises for the cervical spine would be strengthening of the deep cervical flexors, like a chin tuck or chin tuck against gravity, or a chin tuck with a resistance band. Scapula stabilization exercises like push-ups and planks and shoulder taps. Thoracic mobility exercises like open books and thread the needle, and any type of twisting, stretching exercises. Controlled cervical motion. So just watching your motion and your head, turning your head nice and slow and controlled. Improving your postural endurance, being able to sit with good posture for a prolonged period of time. Posture education. So I spend a lot of time working with people on correct postures in sleeping, correct postures in sitting, standing, lying, any type of positions, working at a computer, working at a desk is a huge one. So I spend a lot of time going over the proper posture and proper placement of the screens and the mouse and the keyboard at your desk. Then another treatment we could do is vestibular therapy. So especially for the cervicogenic dizziness cases. So usually if the dizziness remains, we'd start vestibular therapy. And vestibular therapy starts with balance exercises. Can you balance one foot in front of the other with eyes closed? Standing on one leg with eyes closed, one foot in front of the other with head turns or head nods or diagonal turns. Habituation exercises. So habituation exercises are exercises that purposely make you dizzy to make your vestibular system work harder. So people hate it. It's kind of like going to the dentist, where you hate going to the dentist, but if you don't go, your teeth are going to fall out or your teeth are going to rot. So a vestibular habituation exercises, you need to do things that make yourself dizzy in order to increase input to the vestibular system and make your vestibular system stronger. Then we do visual motion exposure. A lot of times people with cervicogenic dizziness and all types of dizziness, they have a hard time being in visually stimulating environments. So like walking through supermarkets, walking through Times Square, walking through some Las Vegas casino, something like that. So you have to kind of build up to be able to tolerate that motion. And vestibular ocular training. So VOR training is often looking at objects while you're turning your head side to side and trying to keep that object steady. Next, we'll do cervical proprioception training. So cervical proprioception training is pretty cool. People usually have a fun time with it. It's often underused modality in physical therapy, in training. What we usually do is, first, let me explain why we're doing it. Like when you sprain your ankle, most people have sprained their ankles before. So you sprain your ankle swells, you get the tissue heals, you get your range of motion back. And then what you're supposed to do is retrain your ankle proprioceptors. So that's why you have to do balance exercises after an ankle sprain so that you're less likely to sprain your ankle again, because you have these receptors in your ankle that tell your brain where your ankle is in space. So when you tear the ligaments or you sprain your ankle, these receptors get disrupted and they change. So you have to retrain them for a few weeks to get them back, and then it's less likely that you sprain your ankle again. Now, you have the same receptors or proprioceptors in your neck. So if you get a whiplash injury or you get a concussion, some of these sensors have been disrupted and we need to retrain them. So one of the ways to retrain them, you're not going to balance on your head. So we do this thing called, it's like a joint position error, we call it. Joint JPE or joint position error. I have a hard time saying that word, error. So what you do is you take a laser pointer and you affix it to your forehead, and you face it towards a target. All right, that target could be anything, and then you close your eyes, you turn your head to the side and back, and you try to realign yourself with that target. And you're going to be off the first couple of times, and then you'll get used to it, and you turn your head in all different positions. There's also like mazes that you could go, kind of moving your head with this laser pointer through mazes. So you're training these cervical proprioceptors. So a lot of times when people have prolonged dizziness or prolonged headache due to cervical or neck causes, I often will train their cervical proprioception. And this is one of the things that are often overlooked in traditional physical therapy or any type of rehab care. Then we're going to talk about my favorite biofeedback and self-regulation exercises. So a lot of times, like, people have been to many different doctors, many different physical therapists or chiropractors. Everyone's telling them different things. They're getting frustrated. They're getting scared. So I need them to train their autonomic nervous system. So training your autonomic nervous system, you're training heart rate variability, right? You're doing breathing exercises. We could do extended exhale breathing. We could do box breathing, pace breathing. I usually do this with heart rate variability biofeedback so we could see what the best patterns are. Also, I like using things like body scans, relaxation training, any type of meditation, and some other mindfulness exercises. So these are all helpful in getting your nervous system back on track or getting more parasympathetic activity into your autonomic nervous system. The next thing I like to add into my treatment is pain reprocessing therapy or somatic tracking. So pain reprocessing therapy is basically, it uses activities like somatic tracking to rewire your nervous system. We're trying to get, when you've had these symptoms for a while and they're scary and you're getting frustrated and worried that something worse is going on, you usually try to ignore those symptoms. So instead of ignoring those symptoms, we're going to lean into them. We're going to close our eyes and you're going to really feel those symptoms. Kind of what I'll usually say to people is close your eyes, picture you're in a dark room, and there's a spotlight shining right on those uncomfortable sensations, whether that uncomfortable sensation is dizziness, nausea, neck pain, headache. You're going to focus on it and you're going to slow your breathing down, really focusing on it. Then you're going to convince yourself of some safety thoughts. So you're going to tell yourself, hey, I've been doing all the right things. My symptoms are improving. I'm seeing the right medical professionals. And you're going to kind of reinforce thoughts of safety. And know that these symptoms are fixable, they're changeable, they're safe, you're safe, and your symptoms are not dangerous. So we're trying to reduce fear and reduce amplification of symptoms. The next thing I'll do sometimes if the symptoms are persisting really long is neurofeedback. So neurofeedback is a type of biofeedback. But instead of looking at heart rate variability or muscle tension, we're looking at brain waves. So we're trying to get people to stimulate more alpha waves. So alpha wave training, and try to avoid those high beta waves, which are the high beta waves are more sympathetic when you're mobilized or when you're in fight or flight, you're going to produce more beta waves. When you're more relaxed and calm, you'll produce more alpha waves. So usually in chronic cases of people with headaches, post-concussion symptoms, hyperarousal, poor sleep, autonomic dysregulation, I like to do a little bit of neurofeedback also, just to kind of make sure that we know what it feels like to get those brain waves stimulated. So most people with cervicogenic headache and cervicogenic dizziness do best with a combination of treatments, combination of neck treatment, vestibular rehab, nervous system regulation, movement confidence, gradual progression of exercises, and consistency. So if imaging is normal, but your symptoms remain, that doesn't mean that nothing is wrong. It may mean that the problem is functional, and functional problems often respond well to skilled rehabilitation programs. So you want to make sure if you're having these symptoms and the doctors are telling you there's nothing wrong with you, go to a different doctor, right? Go to a different doctor, right? Like, people are usually pretty intuitive. And again, maybe that problem's your nervous system. Maybe it's your vestibular system. Get to the right people, get to the right physical therapist, get to the right medical provider, and you could take care of these symptoms. They're all very treatable. Thanks for listening to the What's in Your Head podcast. If you know someone dealing with headaches, dizziness, neck pain, or persistent symptoms, feel free to share this episode with them. And like always, if you could give us a 5-star review, that's even better, so it could help more people find us. To learn more, you could visit Dynamic Sports Physical Therapy or dynamicsportspt.com to make a physical therapy appointment, or you can go to pain&dizzy.com to learn more about pain and dizziness. I will see you next time.